So much, Peggy, for that introduction. And can you guys hear me okay? Okay. Um, so here is my outline for the presentation. Today, I will be briefly reviewing the types of diabetes and goals of treatment, review the diabetes medical management plan, provide information about diabetes technology and appropriate treatment of hypoglycemia, and a brief discussion of diabetes and exercise. I just want to begin by thanking you for providing outstanding care for our children in the school setting. You are critical members of our care team and the students' primary advocate for their health and safety during school. I encourage you to form relationships with your child's endocrine doctor and diabetes educator, and please reach out to us if you notice when your children are struggling with their diabetes management. So as you know, diabetes is a condition where the glucose is higher than normal, and a diagnosis of diabetes is made when the fasting glucose is 126 or higher, or when the A1C, which estimates that average blood sugar over the last 3 months, is 6.5% or higher. Briefly, there are two major types of diabetes. In type 1 diabetes, the pancreas is unable to make insulin because of an autoimmune condition. And in type 2 diabetes, the pancreas makes insulin, but the cells of the body don't respond appropriate to this insulin because of insulin resistance. And there are many other types of diabetes that I will not be touching on today. Because there's a significant relationship between the child's glucose control and their well-being and the need to prevent long-term complications of diabetes later in life, we want to strive to keep the glucose levels in goal range. For children with type 1 diabetes, the goal A1C is at or below 7.5% for those on insulin injections and below 7% for those on a hybrid closed loop insulin pump with a continuous glucose monitor. The goal pre-meal glucose ranges is typically 90 to 130 and 2-hour post-meal glucose goals under 180. Because children with type 2 diabetes are much less likely to have hypoglycemia, the glucose goals are lower, with a goal A1C of under 6.5% and fasting glucose of 70 to 120 and a 2-hour postprandial glucose under 150. For children on a continuous glucose monitor, the goal is to keep the glucose in the goal range 70 to 180 at least 70% of the time, with spending less than 4% of the time with low blood sugar. All of your students should be arriving to school with a Diabetes Medical Management Plan, or DMMP. This is a comprehensive document laying out the individual care plan for the student. It is essentially the doctor's orders and was developed by the healthcare provider along with the parent or guardian, and specifically addresses all of the following aspects of diabetes management, including the timing and preferred way to check glucose and specific details regarding the use of the continuous glucose monitor, the types, timing, doses, and preferred way to give insulin, whether there are any specific dietary restrictions, what to do if a child has hypoglycemia or hyperglycemia, when to check for ketones and how to treat ketones, how to manage the diabetes around the time of physical activity, and specific instructions about how to use exercise settings in the insulin pump therapy, and emergency instructions and contacts, and how to contact the diabetes doctor. I always put my email address on these documents, and I encourage you to reach out to us if you have any questions about that plan. In addition to the specifics of how to manage the diabetes, families are asked to describe details about the student's level of independence and self-care. For example, in the section on glucose monitoring, the family can choose full support, which means that the child requires trained diabetes personnel to check, in this case, blood glucose, supervision, or self-care, which is when the student can independently check their own blood sugar. If your school district doesn't have a sample DMMP to provide to families to fill out, you can find an excellent form created by the American Diabetes Association in the first link here. And in addition, on the American Diabetes Association website, there's a link for basic diabetes training for non-clinical school staff. This is a 19-module training curriculum with key information about different diabetes care tasks, and there is a guide for school personnel on the website as well. You may find this helpful when preparing the primary teacher of an elementary student with diabetes, for example, and coaches or gym teachers who want to specifically receive more in-depth training on topics like hypoglycemia. Of note, if your school receives federal funding, Section 504 of the Rehabilitation Act of 1973 prohibits discrimination on the basis of disability and protects children with diabetes from discrimination. So schools are required to meet the needs of students with diabetes as well as they meet the needs of students without diabetes. For example, schools should provide trained staff to monitor blood glucose levels, administer insulin, and give glucagon as needed, and have trained staff to provide diabetes care during field trips and all school-sponsored events. There are different state laws specifying who is authorized to administer insulin. In New York, for example, only licensed healthcare professionals like the school nurse can administer insulin, but in California, unlicensed school staff can administer insulin. As you know, insulin is delivered by a pen, syringe, or an insulin pump to any of the areas noted in yellow, including in the upper outer thighs, buttocks, abdomen, and the backs of the upper arms. And every year, there are more and more brands of insulin on the market, so it is vital that you learn the types of insulins that your students are on. But in general, they fall under familiar categories. The rapid-acting insulin is what you'll primarily be using during the school day at mealtime or to treat hyperglycemia, and this is what's also in the insulin pump. These insulins work within 15 minutes and last up to 4 hours. So if this insulin is given for the meal, the student should be eating within 10 to 15 minutes. Here's just a graphical representation for your records of the duration of insulin action for the different types of insulin. Your students may be on one of a handful of different types of insulin regimens. The first and the most common, and this is what we do with the pump too, is the adjustable bolus insulin therapy. With this insulin, the child receives a dose of long-acting insulin via a pen or a continuous short-acting insulin infusion via the pump. And then they receive short-acting insulin for meals and snacks, which is dosed according to the number of carbohydrates that they'll be eating. So for example, 1 unit of Lispro insulin for every 10 grams of carbohydrates. The child also receives short-acting insulin if the pre-meal glucose is high, according to the blood glucose correction scale. For example, 1 unit of aspart insulin for every 50 points over 150. And another way of saying this particular scale is a target glucose of 100 with a correction or sensitivity factor of 50. The second type of insulin regimen is listed in the middle. This is the fixed bolus insulin plan, where the child receives the long-acting insulin and the hyperglycemia correction in the same way as plan number 1, but instead of using an insulin to carb ratio, the amount of insulin with each meal is fixed. So for example, the child might receive 5 units with lunch every day or 2 units with snacks. And the third type of insulin regimen, which we really don't prescribe anymore, is when a child receives a combination of an intermediate acting insulin and pH plus regular insulin before breakfast at home. And this is to cover the lunch needs, and then the child receives a second dose at home before dinner. Now, most of your students will be wearing an insulin pump. This is a battery-powered device that administers insulin in a steady release of rapid-acting insulin that mimics the Lantus or the basal insulin, but it's given as a rapid-acting insulin. The insulin pump holds a set amount of insulin in a reservoir, and it delivers it into the body via the skin, and from there it enters the bloodstream. Insulin can be administered as a bolus for food before meals or for high blood sugar with the press of a button. The insulin pumps will calculate the doses of insulins for meal using the insulin to carb ratio calculation and the hyperglycemia correction doses. And some insulin pumps have an infusion set that connects the pump to the body through a tubing system. This is pictured in the top right, and some pumps adhere directly to the body through a patch with a small cannula under the skin, like the pump featured in the bottom left picture on the upper arm. There are a few different types of pumps. So some children might wear a pump and also wear a sensor, but those don't communicate with each other. But most often, children wear an insulin pump and a continuous glucose monitor that do communicate with each other, and this is called the hybrid automated insulin delivery pump or closed loop pump. And examples of this are the Omnipod 5, Tandem with Control-IQ, Medtronic 780G, the iLet pump, and there's a brand new pump that just hit the market in July that's called the Twist. So in these systems, it is important to manually bolus the student for meals and snacks, but the pump automatically increases or decreases the basal insulin delivery before and after meals in response to the blood sugar numbers on the continuous glucose monitor. Less often, children will wear a commercially available pump and a CGM, but use a non-FDA approved open source algorithm for automated insulin delivery. And last, not really available yet, but we would love to have a pump just do everything, including mealtime insulin, but that just doesn't really happen right now in 2025. When interacting with insulin pumps for the first time, or if it's been a long time since you've had a student with an insulin pump, some key skills to master are, number one, learn how to deliver routine boluses for carbs and high blood sugar. You may find it helpful to schedule a time to meet with the child and the family before school starts to become acquainted with the pump and other diabetes technology equipment. Two, identify signs and symptoms that the pump site might need to be changed and know how to change that infusion set. Three, know when an injection by a pen or syringe is indicated. And it's important to have backup insulin pens or syringes for this occasion for all kids who are on insulin pump technology. And four, learn how to disconnect or suspend the pump. This is needed when the child's glucoses are dropping rapidly, or they're unable to consume enough carbohydrate to raise the blood sugar quickly, or when instructed to during physical activity like sports or PE, as noted in the DMMP. So pump malfunctions do happen, and when they do, there is high blood sugar and a high risk of diabetic ketoacidosis from a lack of insulin infusion. The DMMP should lay out the signs and symptoms of what to do when there's concern for pump malfunction. And in general, it is recommended to give a hyperglycemia correction when the blood sugar is above 250 and recheck the blood sugar in 1 hour. If the blood glucose has not started to decrease, or if the CGM arrow is rising after an hour, it's recommended to change the insulin pump site and give a manual injection of insulin using an insulin pen to treat that blood sugar right away. So I wanted to take a couple of minutes to point out a few key features for the insulin pumps that you'll most commonly see this upcoming school year, beginning with the Omnipod 5 automated insulin pump. This pump is really effective for lowering glucose levels into the goal range, but in automated mode. And unfortunately, with their algorithm, oftentimes students who have had prolonged high blood sugar for a while, their maximum basal rate has been too high for too long. So the pump kicks them out of automated mode and puts them into manual mode. And so one key thing to do with this pump is to just make sure that that student is in automated mode. And you can easily switch back to the automated mode with the switch mode option on the pump menu. The background basal insulin rate is not determined by the programmed basal rates that you're going to find on the DMMP. It's actually determined by a secret Omnipod algorithm that takes into account the user's total daily dose and target glucose. So if the blood sugars are typically high at school, one common fix is for the physician to change the target glucose to the lowest setting, which is 110. As in this pump, the target glucose can be anywhere from 110 to 150, depending on where the physician put it. There is a variable duration of insulin action in this pump, and I do recommend utilizing the activity mode feature during gym and sports. This targets the blood sugar to 150, and it prevents low blood sugars. This is especially helpful with cardiovascular exercise. When students have just strength training, their blood sugar may actually rise with that activity, and so the activity mode might not be necessary. And then there's a really useful feature called custom foods in this pump, where the family can program in the child's frequently eaten snacks and meals to simplify mealtime bolusing using the custom foods feature. Second, the pump that I'm going to mention here in more depth is the Tandem t:slim and the newer Tandem Mobi, both of which use the Control-IQ automated insulin delivery algorithm. These pumps are always in automated mode, so you don't have to worry about putting them into automated mode unless there's an issue where the child's not wearing a continuous glucose monitor, or for some reason it's just not communicating with the pump. The automated basal insulin rates actually is based on the program basal rates that you will find on the DMMP, and their target glucose is always set to 110. Their duration of insulin action is always set to 5 hours. And they do have an exercise mode, which again, I do recommend utilizing with gym and sports if the kids are dropping. And this targets the blood sugar to 140 to 160. Okay, now on to continuous glucose monitors and those alarms. So CGMs are incredible tools that monitor the change in glucose levels and alert users and their guardians to low blood sugar and reduce the burden of the painful finger sticks. The CGM alarms are prescribed by the healthcare provider with input from the student and parent, and it is recommended that the audible CGM alarms be set to be actionable in the school setting, such as for hypoglycemia when there's an acute risk. If a CGM alarms, it is recommended to follow the instructions in the DMMP. All students, regardless of their level of independence, will require assistance when they experience severe hypoglycemia, and they should be accompanied or escorted if they're going to the health room. As you know, CGMs are capable of sharing data real time with the parent and school nurse remotely if desired. And while it is not required for school nurses to follow the student's glucoses remotely, it is strongly recommended as this provides an additional level of safety for the student. It is not necessary for the school nurse to actively follow the glucose levels all day long, but to at least be aware when the alerts are going off in the remote monitoring. For legal reasons, it's recommended for the nurse to follow the glucoses on a school-owned device. And of course, we know that the parents or guardians are following the sugars at home, and that can lead to excessive phone calls and communications from families during the school days. So the parents should be reassured that there are a lot of safeguards built into the school with a lot of adults around, and that schools are well trained to respond to urgent situations related to diabetes. For information on general treatment recommendations based on CGM and follow the DMMP. And then I also just have this as an informational slide for you as well. Now, hypoglycemia. This is when the level of glucose in the blood falls too low for the body to function properly. It must be treated immediately, as very low blood sugar can lead to unconsciousness and seizure if left untreated. Mild hypoglycemia is a glucose under 70, moderate is under 54, and severe is when there's a mental status change. Hypoglycemia can look like sweaty, shaky, heart racing, extreme hunger, restlessness, irritability, confusion, sleepiness, all the way to those severe symptoms. So for all these cases, again, do not leave the child unattended. Follow the instructions in the DMMP for treatment. But in general, for mild hypoglycemia, we verify that the glucose is low and give a fast-acting carbohydrate. For older kids, we follow the rule of 15 grams of carbohydrate, check the glucose in 15 minutes, and the glucose should have risen at least 15 points, and repeat every 15 minutes as needed. For younger kids and for kids on automated insulin pump, they will need less carbohydrate to raise the sugar. And so one rule is 1 gram of glucose for every 9 pounds of body weight, or, instead of 15, maybe give half of that, like 8. So many students will come with our newer user-friendly glucagon products, such as the intranasal spray and the premixed subcutaneous injection of glucagon that's seen in the bottom photos here. For severe hypoglycemia, we recommend placing the child on his or her side and lifting the chin to open the airway, injecting the glucagon per the student's DMMP, and calling 911 and the parent. The student really should have a rise in their blood sugar within 15 minutes. And if they don't, you can repeat another glucagon injection. Avoid putting anything in the student's mouth if they have the altered mental status until the student is truly able to swallow. Okay, and we're rounding the corner here, finishing up with ketones. So identifying ketones in students with diabetes is necessary to prevent DKA, the life-threatening diabetes emergency. This is when cells aren't getting the glucose because either severe insulin deficiency, we miss doses, or severe resistance to insulin in the case of type 2 diabetes. And the body starts to break down fat to use as energy, and the byproducts are ketones, which poisons the body. And symptoms of ketones and DKA include that fruity smell on the breath, but of course, hyperglycemia. Most commonly, it's a nausea or vomiting or belly pain. So students might feel like they had something bad to eat the night before, but really it's probably their insulin deficiency and they need more insulin. So you can check for ketones using urine ketone strips or blood ketone meters. And when present, give that correction dose of insulin with an insulin pen and extra water per the DMMP. Presume there's a pump site malfunction. If the child's on an insulin pump, and replace that pump site, notify the parents and repeat the ketone check and glucose check 2 hours later. If the child is vomiting and can't hold down water or appears particularly ill, or the ketones aren't improving after a couple of hours, the child will need to go to the ER for IV hydration and further treatment. So physical activity, and Peggy, I know I'm running over, so just maybe stop me. I think I have just like 2 more slides here. But physical activity will impact glucose levels and the amount of insulin needed. Follow the instructions in the DMMP. We generally want a higher target going into the exercise to prevent a low. And here's just some guidelines for your information. And then last but not least, I just want to make a point about how we as healthcare professionals can combat the stigma related to chronic illnesses that our students have on a day-to-day basis. They did a poll of children with type 1 diabetes, people living with type 1 diabetes, and 76% of them experience stigma, 50% of those living with type 2. And so one small way that we can do to combat this is to carefully choose respectful, inclusive language when addressing students with health conditions. And so here's a list of small language shifts published by the Diatribe Foundation to reduce diabetes and obesity stigma. Instead of referring to someone as diabetic, try a person with diabetes or a person living with diabetes. The term disease has a negative connotation and brings to mind something contagious or gross, so use the term condition. And instead of using the phrase testing glucose, maybe checking glucose, because the term test is associated with grades and passing and failing. And then, yeah, last, don't refer to glucose numbers as good or bad. This is so hard to do, but try instead just saying that the glucose numbers are above goal range or below goal range, and that will reduce that stigma there. So this is the conclusion of my presentation. This is my contact information. I am in clinic. I don't think my next patient has checked in, so I'm going to try to answer as many questions in the chat as I can. Unfortunately, I won't be able to attend the Q&A, but I'd be happy to answer questions over email, so please don't hesitate to reach out. Thank you.
It looks like Peggy got called away. So a huge, huge thank you, Dr. O'Sullivan. That was an amazing talk. Thank you so much. I think there's a gob of questions for you. So thank you in advance to any that you can answer. Anything that's in the Q&A, we can send to you afterwards. And if you have a chance, we can then distribute it to the entire group. So thank you, thank you, thank you for this. And our next speakers are here. Our next topic of the day is caring for the student after an ICU stay. This is a new topic for us this year. We are so grateful to Ionis Fokadis and Samantha Panazzo to come and speak to us on this topic today. Ionis is a clinical instructor of pediatric critical care here at Comer Children's Hospital, and Samantha is a pediatric critical care registered nurse. Welcome. Thank you so much for being here.
The audio is a little quiet right now.
A little bit. Are you guys able to hear us a little bit better this way?
Much
Yes.
better, thank you.
We were trying to use AirPods, but it seems like that might not be the best option. Are you guys able to see our screen?
We are seeing the presenter view. Can
The
you
presenter- Yes, give me one moment. I'm not sure why it's doing that. One moment, please. Honestly, I think having two might not work. Okay. How about now? Is that a little bit better?
Yes, perfect.
Okay, just one moment, and then we'll be starting.
Thanks for joining us. Sorry, I had some technical difficulties. We are so grateful that you're here. Thank you so much for being here. How are we doing?
Hi, sorry about that. Just a little bit of technical difficulties. Tried to be technologically advanced and use more than one screen, which didn't seem to work out in our favor here. So good morning, everyone. Thank you so much for having us. My name is Ione. I'm one of the doctors in the pediatric ICU at Comer. And this is Sam.
Hi, I'm a registered nurse in the pediatric ICU as well.
And we're very excited to be here to talk to you guys about taking care of our patients after discharge. So before we begin financial disclosures, I do have grant support through an NIH T32 grant for a project that is unaffiliated with this presentation, but wanted to disclose that. Samantha does not have any relevant financial relationship to disclose for this presentation, and neither of us will be discussing any off-label or investigational use of any medications or therapies during our talk.
So introduction to the pediatric ICU or PICU. So the first established pediatric ICU was in Europe in 1955, and pediatric critical care was established as a distinct subspecialty in 1981. Some of the most common reasons for admission that we see in the pediatric ICU include respiratory illness, injury or poisoning, sepsis and shock, cardiac disease, neurologic disorders, and trauma. So pediatric critical care, critical illness mortality, we're seeing have made improvements through advancements in medical knowledge, therapies, and technology. And morbidity is often increased due to the prolonged hospitalization required in our critically ill patients. This recognition of the morbidity burden on both patients and caregivers has led to what we will be talking about today, but the development and advancement of the post-intensive care syndrome, PICS, post-intensive care syndrome pediatrics, PICS-P, and the post-intensive care syndrome family, PICS family.
So in pediatrics, as many people know, a lot of our research is something that we have then adjusted from adult research initially. So like many other things in pediatrics, the post-intensive care syndrome, PICS, was first identified in adult critical care. And then the decision was made by researchers to try to implement this same framework into pediatrics. So that was adapted, creating what is known as PICS-P. And they identified 4 key domains of potential impairment in both the patient and their social support system. So those 4 pillars are mental health, cognitive function, physical outcomes, and social functioning. Some of the risk factors that we see in our patient population that's been studied and identified as very key risk factors for PIXP are the use of prolonged mechanical ventilation, the use of prolonged sedatives and opioids, as well as corticosteroids. The first two are usually very, they go hand in hand, for lack of a better term, because often in our patient population that requires mechanical ventilation, they're often very afraid and scared, and often in our very young population, they're nonverbal at that time. So they do require a heavy amount of sedatives and analgesia to make them both not feel pain and to not be distressed or in discomfort, particularly when they're critically ill. We do make a conscious decision as their course continues and as their initial etiology for requiring the mechanical ventilation improves to decrease our sedatives and opioid use or analgesics in our patients, but that's often not possible while they're convalescing with their illness. A prolonged stay in the PICU of greater than 7 days has been shown to have an increased risk of developing PIXP. Patients of a young age, anyone with a pre-existing behavioral health concern, whether it's a formal diagnosis or not, lack of social support, lower economic status, and limited access to healthcare are also very important in the development of PIXP. So this is a graphic here that represents the interweavings of PIXP on both the patient and their support system. So as you can see at the top of the graphic, everyone has a baseline status, and that is different amongst everyone really, and even different ages. But that is how they come into before their sickness, I would say, before the ICU. And then their time in the ICU can be effective of that baseline status. Both of the child and that experience can affect their social support and then their caregivers as well. As you can see, the child can be affected in all 4 of the pillars, so physical health, cognitive, emotional, and social, whereas the social support and the caregivers of the patient primarily are affected in the emotional health and the social health pillars. Regardless of if all 4 are affected, if one is affected, if the child and the family is affected, or if it's just one or the other, there is an impact on the development of that family unit as well as the individual patient post-discharge from the ICU. And that recovery back to their baseline or their new baseline is a non-linear recovery trajectory often in a lot of our patients. Which is a fancy way of saying that everyone takes their own amount of time recovering back to how they were prior to their stay in the ICU.
Yeah, so some of these PIXP symptoms, kind of going off of that slide, and we talked about the physical, emotional, cognitive, and social part, but kind of breaking those down, physical symptoms, we can see weakness, loss of developmental milestones, sleep disturbances. Emotional, we can see depression, anxiety, and PTSD.
Excuse me, just to interrupt really quick. It looks like your video is imposed over your PowerPoint presentation.
Oh, that's bizarre. Like you're seeing us over.
Yes, we're seeing your video is kind of partially covering your PowerPoint. Could you try resharing?
Yes, absolutely. Give us one moment.
It's a feature in the top right hand as you're sharing. You can turn it on or off.
Okay.
Oh, darn.
Is that better?
Perfect.
Okay. Thank you for letting us know. Apologize for that.
Yes, thank you. So continuing cognitively, we can see difficulty with attention. We see behavior changes. We see a decline in school performance. And then socially, we're seeing a loss of peer relationships. There's a lot of like seclusion and isolation in your ICU stay with your life pre-ICU, and everything that comes with that. So we see difficulty or loss of peer relationships, difficulty with social interaction, and absenteeism. So physical health, in the intensive care unit, we can see like an increase of weakness, and it's characterized by loss of muscular function and power, neurologic ability, pain, and cardiopulmonary function, which it can be challenging to recognize in like diagnoses in the pediatric population. But we can see also that there are studies that have shown a discrepancy in the identification of functional status decline at the time of discharge between providers and parents or caregivers. So as far as provider identification, we can see a 10.3% like identification of functional status decline versus an almost 82% of identification in that functional status decline in the parent and caregiver population. We also see large clinical trials that indicate 56% of patients had a functional improvement, with 82% returning to their baseline or only having mild dysfunction.
Cognitive health is a pillar that I would say is particularly difficult to identify in our patients. But when it is identified, the primary deficits that we see are in attention, memory, and or processing speed. The reason for the complexity, I think, in this pillar is that often patients, just the way that they have a different physical baseline, often have different neurocognitive deficits at baseline. So that's a fancy way of saying that children can have learning disabilities, they can have processing disabilities, and then just in general, different baselines cognitively before their stay in the ICU. So that makes it particularly difficult to be able to study and pick up on these changes of these baselines pre and post hospitalization. And there's also a lot of recall bias in the testing that is done to help measure any functional decline in this pillar as well. So that's something that's been seen in literature, that it's often easy to, in hindsight, say, oh yeah, of course, we've seen that this patient has had, you know, a little bit of a delay in their speech and their ability to cognitively understand when we're speaking to them after a prolonged stay in the ICU. But is it that we are kind of having a bias in that because we now see it already in the patient? Because it's often easy to forget to how they were prior to this critical illness. And oftentimes when we're meeting a patient, they're already critically ill, so we don't even get that baseline to begin with. So we rely heavily on parents and family members and caregivers who often at the bedside show us videos of their loved one before this hospitalization, and we're attempting to, you know, make decisions and evaluations based on, in a way, secondhand information. And this is evident in gaps of both identification and research in this pillar, because it's just a difficult pillar to be able to develop critical research regarding. And we can see that children are frequently presenting with the same continued deficits all the way up until 12 months post-discharge in follow-up appointments. So the way that a patient is discharged from the ICU with any deficits can be something that is prolonged for a full year in time. And it could directly affect a child's ability to participate in education, their school performance, and educational attainment. So this makes it a particularly important pillar for those members of the audience that develop that rapport with patients and are seeing them perhaps daily or frequently throughout the week in a school setting, and might be able to pick up on these deficits quicker than their primary care physician, who they might see periodically every few months. Definitely would be able to pick up on it faster than one of us in the ICU that tends to meet a patient when they're critically ill and doesn't have any follow-up with them. So this is something that's, you know, a very particular importance to be conscientious of, and definitely rely heavily on our colleagues in the educational department to help us pick up on this.
Yeah, so moving on to emotional health. So it may present as mood, psychological, psychiatric disorders like PTSD, depression, anxiety, phobia, sleep disturbances. And we're seeing PTSD in almost 85% of PICU survivors when compared to ward survivors, which is a 6.2%. And then peak trauma, we're seeing it present 12 months post-discharge in up to 40% of our patients. And then also evidence is suggesting that psychological morbidity is a result of physical manifestation in the 6 to 12 months post initial discharge. So to give you guys some context, we have a patient who has been in our pediatric ICU on ECMO and who recently changed rooms for a quality improvement initiative that we have in the unit. So as far as a nursing standpoint, we're looking at this patient moving rooms to improve quality and risk like infection, like her infection risk or decrease her infection risk. But this has had profound disturbances on her. So something is, we're seeing as like maybe minuscule as moving rooms has had like significant detriment in her sleep-wake cycle. She's had sleep disturbances in the middle of the night. She seems more anxious and scared overall. So we're seeing this as play into her emotional health, but she also has like increased risk factors for the PICS-P, like prolonged mechanical ventilation and sedation use. This is Jacob, a 16-year-old male who was included in a study out of the United Kingdom of patients who had a PICU length of stay that had near-death experience. So he was in the PICU for 17 days with an underlying diagnosis of ischemic cardiomyopathy, which led to cardiac arrest and subsequent heart transplant. So this is just, real life experience. And this is his words here of PICS-P at play.
We can read this just to give everybody some time. So they put me to sleep for an operation, but I was lying there paralyzed and I could hear everything the doctors and nurses were saying. Like, is everyone ready to stop this? It's like I had this knowing of what they were doing. It was like I'd been taken up to a bird's eye view, but I couldn't see, only hear and know. I was above just listening to everything. Even though it happened 4 years ago, I remember everything like it only happened yesterday, like a flashback. So I think this is a very strong statement from a young man who clearly went through something that was both impactful physically and emotionally in both him and I would imagine his caregivers' support. And as an ICU provider, we are very conscious of what we're saying and how I'm communicating with my bedside nurse who a lot of the times the verbiage that we use is very medical. It's very succinct and often is what we need to help the patient, succeed physically and to not have a critical decline. But often it's perhaps not the most calming verbiage for a patient that is aware of what is happening around them. So moving on to the social health pillar, as we've alluded to, it affects both the patients and their caregivers, with some primary concerns in literature being social isolation in our children, the patient, parental stress and loss of employment. We make every effort to have the family members and the social support system and caregivers come visit the patients when it's safe to do so. But in real life experience, a lot of parents or caregivers are hesitant to have their other children and siblings come see their child when they are attached to a ventilator. They have IVs sometimes in their necks. There's the breathing tube coming out of their mouth. There can be electrodes on their scalp, looking at their like electroactivity in their brain. And it can be a very scary environment for people that are not in medicine. Whereas, oftentimes I acknowledge that it's a very comfortable environment for us because that's where we work, but it can be a very scary environment for especially other younger siblings as well. There is a social stigma and a loss of identity that may also result in some additional stressors, particularly in an adolescent patient. Anyone with a prolonged hospitalization is suddenly ripped away from their life. So for a 17-year-old that's getting ready to go to prom, being admitted to the hospital and ultimately intubated, getting a liver transplant, and ending up in our PICU for weeks to months is a huge change from their baseline and their norm. And that's something that not only has effects in the moment, but can have effects after discharge as well. School attendance actually in literature has shown to be a very strong objective measure of the social impact of PICS-P, with 43% of children having missed 7 or more days and 43% having missed more than 30 days. And additional studies actually demonstrate that the psychosocial impact on caregivers with in patients who have a prolonged hospitalization in the PICU have 9.5% of them receiving a new mental health diagnosis in the 6 months post their child's discharge, which is an 110% increase from baseline. So, again, this is a very important pillar, and I think this is another great example of how our colleagues in the audience can be strong advocates for our patients, especially with the school attendance. That's something that as a metric that we don't particularly know of. And especially in the outpatient realm, we do ask families and children how school is going. But in terms of having that metric of objective data of the amount of days missed is not something that is readily evaluated in the outpatient setting and can be a very important measure of this risk factor for this pillar.
So how do we prevent this? So early identification with our multidisciplinary team. So that includes physical and occupational therapy, our speech paths, and psych included. We want to try to get these patients up and moving early. We reassess their sedation requirements. So how can we decrease this dose? We're reassessing that sometimes hourly to make sure that we set our patients up for success moving forward. We actively screen and manage delirium. So every shift in the ICU, we're completing a delirium screening for our patients on every patient. And then we really try to engage our families and caregivers through use of like Child Life. We have social workers, but also getting them involved in their child's care, pretty frequently and early. So the ABCDEF bundle is like a group of things that we're using to move our patients forward. So we're always assessing, prevent, and managing pain if our patients are experiencing pain. We're testing spontaneous awakening trials and spontaneous breathing trials in our SAT and SBTs. Like I said, we're reassessing our need and choice of analgesia and sedation, which kind of goes along with our delirium. So if our patients aren't requiring as much sedation, as they were at one point, like how do we take that away and chip away at that so we can try to prevent delirium. We're also trying to, as much as we can, mirror their experience pre-ICU to their experience in the ICU. So, waking patients up at an appropriate time, turning the lights on, getting them moving, brushing their teeth, little things like that help pretty significantly with our delirium. And then, mobility, exercise, getting our patients, getting consulted with physical therapy and occupational therapy, and working really as a team to make sure that our patients are as strong as possible for their discharge from the ICU. And really engaging our family and, making them feel empowered to take care of their loved one outside of the ICU.
So how can members of the audience help? How can anybody help? Post-discharge support is a very important realm in PICS-P. So early identification of some of the symptoms that we discussed, offering a safe space for students to discuss any concerns and difficulties. Communication amongst healthcare providers, family, and teaching staff is very important because often we're all working in silos and there's very little connecting us other than the patient themselves. So having that additional communication is profoundly important in these patients and their outcomes. Advocating for your patient's needs, whether that's an individualized healthcare plan or emergency care plans. Mental health support for both the patient and their family and caregivers. Identifying the need for and making referrals, and also educating other staff members and caregivers about the signs and symptoms of PICS-P. Because to be honest, it's a rather new realm and field of research in the pediatric population. It's been in adults for a little bit, but pediatrics, it's definitely something that's new. These are our sources. I know we went through a lot of information, but we have the luck of being right in front of the Q&A session. So we look forward to everyone's questions, and we thank you for your attention this morning.
Thank you.
You so much for joining us. What a fantastic presentation. And as you mentioned, sort of a newer field, but I think as many of you said in the chat, there's such tremendous implications here for how not only school nurses, but teachers, other sort of community-based adults can support children and teens who are going through this and trying to help them in the educational setting. We have a few minutes here for questions, and I think it's really important for us to get this underway. Unfortunately, Dr. O'Sullivan could not join us, but please know that I work with her directly. We will make sure that all of your questions are being recorded that are diabetes related, and we will be sure to answer them. So any of us who are joining, there we go, Dr. Nevin. Great. Dr. Nevin, you may have had the opportunity to answer some of these questions, but I love just sort of this general question as we kick off our first Q&A session. Do children outgrow asthma? Do they outgrow it? Do they have moments of exacerbation then as adults after like losing asthma, right, for years? What can you tell us about sort of outgrowing asthma clinically and scientifically?
So it's actually a great question. And our preschoolers or sort of early school age kids that are primarily viral induced, if they don't have a personal history of atopy, eczema, allergies, and they don't have a strong family history of atopy allergies, they can sort of quote unquote outgrow their symptoms. So when they're not having 6 to 8 viral illnesses, which is common for school age children, they may not have sort of those viral sort of lingering cough or other sort of symptoms of asthma. What's interesting though is as they become adults, if you actually go back and study those and compare adults that had a childhood history of reactive airway disease or asthma to the adults that did not have that corresponding history, and you try to induce an asthma attack in them with medical therapies that we can do that in the laboratory, the ones that had the childhood airway hyperreactivity will statistically be much more likely to react to that stimulus even later on. The thing that I tell parents in that discussion is, you know, we don't go door to door and be like, hi, did you have childhood asthma? You know, and try to sort of induce them into an asthma attack door to door, right? But it's important to know that because some of those children that were severely affected in childhood and then have no daily symptoms, they get through colds fine as teenagers and young adults. When they have their first pregnancy, for example, or, you know, with hormonal stress, or, you know, they have a severe respiratory illness, they may flip back into airway hyperreactivity. The problem that we also see is that oftentimes the symptoms become acclimated to. So it's always hard for people, I think, you know, in general to understand that with asthma, right? How would you not understand that you were having trouble breathing? But we talk about it a lot of times in our ICU. Ione and team can sort of speak very acutely to that, right? Because anything that is chronic in your body, you get used to. That's how a healthy brain operates, right? So, you know, adults who have blood pressures of 240 over 120, they might not feel the headache or the chest, pain or the dizziness because their blood pressure didn't go from here to here. It kind of went like this, right? And so they got used to it. And that is the same with asthma. So we do see some patients that say, "Oh, I outgrew my asthma," but they still have severe airway obstruction and airflow limitation, and they've just gotten used to those symptoms. So it's a multimodal answer. Sorry to take so much.
That's the right answer, right? So there's lots of answers sometimes to one question. So thank you for that. Ione and Samantha, some great questions here about maybe like pre-problem solving, as I like to say, or being really solution driven. So this anonymous attendee said, you know, what do we need to know as school nurses, and how can we sort of advocate for a child who maybe comes back to school, had an ICU stay, maybe we didn't have like a lot of information, we didn't have direct contact with the family during the ICU stay. What can we do? And so as a nurse, as a mom, I'm thinking, how can the nurse maybe reach out to mom and dad and even the student, depending on the student's age, and say, let's talk about your experience, but we also don't want to like re-traumatize the kid either. So like, what would you recommend the school nurse do, in that situation?
What a great question. I think it's going to be pretty challenging to answer just because this is such a new realm for all of us. But I would say lean heavily on communication, as you've already kind of alluded to, Peggy. So talking, I would say initially to the caregivers of the particular student to kind of get an understanding of how the stay happened, how comfortable they are with addressing some of these concerns with the student. And then we really love family meetings. In the ICU, we tend to have a lot of multidisciplinary meetings. I'm sure Mary has been present for quite a few of them as well. And getting everyone in the same room, or now with the use of technology via Zoom, together to kind of talk and put your heads together about the best way to support the student and come up with an individualized plan is probably the best, I would say. It's a little tricky because, as the person that asked the question alluded to, the risk of re-traumatizing the student after their experience is definitely something that is a big concern. But I think that's where I would rely heavily on both the caregivers of that student as well as their primary care physician who have likely followed up with them at least once or twice since their admission.
Yeah, I was gonna say, trying to meet the student like where they are, and not having like these expectations of where we think that they should be in their like experience post ICU discharge. I think we also have a disadvantage of being in the ICU is we often don't discharge patients directly from the ICU. They oftentimes go to the general pediatric floors. And they can be there for months, like post their ICU stay. So I think someone put in the comments, which I agree with, like having a way to navigate the patient's discharge from the hospital and transition back to school with the team that, spent several months with them and kind of got to know them as they were, becoming maybe more less acutely sick and more like transitioning back to their everyday life. I think those conversations and connections could be important for that transition back to school and back to their home life.
Thank you for that. I wanted to acknowledge the number of questions about diabetes. So many of you may or may not know, I'm a nurse and I've been a nurse for almost 30 years, and about 25 of these 30 years have been in diabetes. So I do feel strongly that I can answer some of these questions in the absence of Dr. O'Sullivan. One thing I wanted to answer just from sort of like a self-care standpoint with school nurses is that two people have pointed out in their questions that managing diabetes in a school setting is beyond stressful. I completely agree with you. I think the game has changed without sounding too hyperbolic about using the word game. The landscape of diabetes is changing in that there are more medications than ever. there are more devices than ever. So you may have 3 children with diabetes, all type 1 diabetes, all in the same school setting, all the same age, and they may be on different pumps, different continuous glucose monitors. And then, as you have pointed out, sometimes mom and dad have rules that don't sound like clinical in nature. Maybe they're anecdotal based on what they've seen with their child at home, and they don't often make sense. So I just want to acknowledge to you that this is beyond stressful. And I think it's really, really important for you to have open communication with parents around my job is to keep your child safe in the building. But there's only so much I can do to keep their blood sugars perfectly within range. And you can say to them at the start of the school year, what are your 2 biggest concerns, or what is your biggest concern in terms of keeping your child with diabetes safe in the building? That's the first question. The second thing I'd recommend as a school nurse managing children with diabetes is to let mom and dad know, here are 2 or 3 suggestions that I've been seeing really work for kids with diabetes. Lots and lots of questions here about what the child is eating at lunch and then trying to match their insulin as a result. So reminding mom and dad to send them with sort of higher protein, lower carb lunches is great. If the child is picky, tell them that you're more than happy to like work with them on maybe sending different food with their child or how you can help support that. I think that's really important. And I also will finally say that you have some really good questions around high blood sugars. So high blood sugars can be stressful. You should be checking for ketones based on whatever the physician orders are, above 250, above 300. But more than anything, as a nurse and as a mom, look at the child. Look at the child, see where they're at. Are they nauseated? Are they throwing up? Are they dizzy? Do they feel okay? And then be really thoughtful about whether or not you need to continually dose them with insulin. One of you had a great question about insulin on board. Sometimes the pump will not allow you to dose a child with insulin because it says there's already insulin on board. I would either go in one of 2 directions on that. I would completely believe that pump and wait 20 minutes before you feel like you have to dose them again with insulin. Let's check that blood sugar in 15 to 20 minutes. Let's see if the blood sugar is coming down. If you've dosed them 2 or 3 times with a bolus of insulin, blood sugar is still up or high, you're going to check in 15. Again, look at your patient, check again in 30. And then I might go in the opposite direction, which is the pump is not working, or I should say the site of the insulin administration is not working, and you might need to change the site. So those are all my pieces of information about diabetes. I wanted to answer some of those questions. I do want to go back to you, Dr. Nevin, to sort of think about asthma and think about PRN treatments. Lots of questions around sort of PRN treatments. Mom thinks sometimes that a child is okay to not have any PRN treatments, meaning no inhaler at school, or inhaler at school, but only during gym class, or only when the child has been homesick for 3 days. How do we typically dose or think about PRN treatments for asthma? This is a tough one,
Yeah.
right?
So again, it's a it's a multiple part
Yeah.
answer, right? So, I mean, the bottom line that I would say is that we are getting away from the monotherapy of asthma with albuterol. So using albuterol alone as a treatment for asthma. And there's been fantastic questions in the Q&A, and thank you for those. And a significant percentage of them relate to this specific question, right? So if we are using albuterol, typically if you use albuterol more than twice a week for symptoms, your asthma is considered as poorly controlled. So this is a question that we ask all the time in our clinic follow-ups. If they are using albuterol for symptoms more than twice a week, typically we think about stepping up their therapy, regardless of their lung function in age groups that are able to perform lung function. So we used to use a lot of albuterol prior to exercise as a preventive. We know now that that's not that effective. And number 2, it actually works against us. It increases the eosinophilia. It increases the airway hyperreactivity. So again, that's not a great way to manage asthma, and we've really gotten away from that. It continues to be a big manner of managing asthma in the outpatient realm. And so what I just remind people is that you should have normal exercise tolerance if you're an asthmatic that is under good control. And if you cannot get through exercise without albuterol, then I would recommend going back to the pediatrician or going to a subspecialist and thinking about, is that really asthma or is there another problem, cardiac, other symptoms that can, or other problems that can produce similar symptoms. And if it's asthma and we all agree that it's asthma, then we may need to think about starting a preventive therapy, or if they're already on a preventive therapy, stepping up that preventive therapy. So your exercise tolerance should be normal with well-controlled.
Appreciate.
Yeah.
I appreciate that. I think that's true. Let's talk a little bit about, we're going to switch gears here and we're going to talk a little bit about um, children who have an ICU stay, and whether or not what you're seeing is that the effects are permanent or temporary. So so I think this is really what this nurse is asking. What short-term and long-term goals can we have with the child or with the parents upon return to school? Maybe 1 month after a PICU stay, and then maybe, by the end of the year, right? So like, how do we set goals with families and sort of figure this out and understand what's temporary and what's permanent?
So it depends on, number one, the severity, and number two, the chronicity, right? So if a child is admitted for the first time, and again, we know that severe complications can occur with asthma in children that are previously described as having very mild symptoms or very intermittent symptoms. And that was kind of what I talked about in terms of that impairment versus risk, right? Your kids are the ones that are like, we're fine, we're fine, we're fine, we're fine, and now we're in the ICU. Right.
I appreciate that.
And,
Yep.
and so even we as pulmonologists sometimes can't dig out sort of chronic symptoms that are placing them at risk. But we generally feel that if you're admitted to an ICU with an asthma attack, that you should not be in an intermittent category. You can be in an intermittent category, but we typically say intermittent of a severe quality or a moderate quality, right? That puts you in the ICU. And then that, according to those guidelines, still needs a preventive therapy. So it really depends on, it's a broad, again, question, right? And it's a very good question. But if you have a child who's on the ventilator and sedated because they're on a ventilator for 10 days with status asthmaticus and pneumothorax and pneumomediastinum and other sort of severe complications of asthma, and maybe they had cardiac arrest with their asthma attack, which of course we unfortunately see, well, then that child's going to take longer to return to baseline. If you have a child who's chronic, and has chronic inflammation, no inflammation in the body goes from here to here in a day, right? Or even in a week. That's true of diabetes, that's true of asthma, that's true of every type of inflammation in the human body. And so they may need a period of oral steroids and or a length of time, even 4 to 6 weeks of an inhaled corticosteroid or an ICS/LABA before they start to evidence improvement with their asthma. And so it just sort of depends on the severity and the chronicity. But in that in between time, what we're looking for is gradual improvement. If they're coughing daily, we want to see a decrease in that. If they're having chest pain and dyspnea with exertion, we want to see a trend towards increased exercise tolerance. If they're coughing through the night, we want to see a decrease in that. We want to see many of these patients come in, one in particular just today, who's using albuterol around the clock, every 1 to 2 hours around the clock. We tell people, if you need to use albuterol more than every 3 to 4 hours, you need to be in an emergency room.
I appreciate that. Thank you. That's a great way to end, but Ione and Samantha, I wanted to see if you had any final thoughts here. And again, we're a little over time, and that's my fault. I'm trying to get every question answered. We have about 8 minutes until our break. But Ione and Samantha, any closing thoughts on that?
Yeah, that's such a great question. And just kind of piggybacking what Mary said, it really just depends on the reason that the patient was in the ICU and what their new baseline looks like. So I think this is where I would lean heavily on communication with their primary physician and their families to get a better understanding of what are the challenges that this individual student might face having just been discharged. For example, if the pillar that is primarily affected is physical, as Mary kind of already alluded to, that could take weeks to months to even years to kind of get a recovery from. If it's neurologic, for instance, we often see patients who've experienced quite a lot of unfortunately violent trauma, and they could have very severe neurologic deficits from that trauma. Their return to baseline might not ever be how they were prior to this injury, but we can set goals for them that are hopefully attainable. And where I think members of our audience would be profoundly beneficial is touching base with the family to find out what their physical, occupational, and speech therapists are working on with them outpatient in therapy, what their primary care physician is looking at as metrics every time they come in for follow-up. How can we support that in the school system, I think is very important. So I know that's not a very concrete answer, but that's honestly the truth because every patient is very different. In terms of cognitive and social support, I think making sure that the family is able to have safe transport for the student to school every day, meal allotments is something that can also be particularly challenging. If you have your child in the ICU with us for 6 months and you're unable to, you know, attend your place of employment and are having difficulties monetarily, you know, there might be food insecurity. That's something that is, you know, can be a profound effect on patients. And I think getting back into a routine often is very beneficial because all of a sudden they went from going to school, going to an after school activity, going home and having their routine to suddenly their days and nights are mixed up. They're in the ICU. They often don't leave the room for prolonged periods of time. And that can be really detrimental to the development of children. So I think our takeaway would be communication. And I think I speak for a lot of people when I say that reaching out to physicians is not something that would be frowned upon. We love the communication. And if there's any concerns, you know, we work in a huge team, social work, we have child life specialists, we have care managers that help facilitate discharge. You know, there's always a lot of resources to help our patients and students succeed.
Yeah, I think
Thank you.
remembering
you.
that the patient is not only going through, the patient has, the set of things that they're dealing with, but the families also are, the Pix family are, going through things as well. So if there are avenues that we can kind of, work with the families to help them best, use that communication and use those resources. Yes, use your school counselor to connect with members of our healthcare team in the hospital or primary care.
you.
physicians.
That's so incredibly important. We're going to wrap this up and we're going to head to our next session. We want everyone to close out this session and join us on the new session. Rachel, I hope that's correct. Rachel's our behind the scenes leader. But we look forward to having all of you join us in just like 3 minutes. I might give us a couple of extra minutes for us to log on to the next session, and maybe we'll start at 10:35 as opposed to 10:30. Thank you again to our speakers. Thank you again for all of you who joined us for the first session. Run to the ladies' room or the men's room or whatever room you choose, grab a cup of coffee, and we'll see you in a few minutes on the next session. Take care.
Peggy, real quick, are the questions still going to be available for answering on Q&A or no?
Great question. Rachel, can you help us with that so that Dr. Nevin and certainly Ione and Samantha can answer additional questions that are coming up in the Q&A from this session?
Yes, we will pull them and we will send them to you guys so you can answer them, and then we'll distribute them to the attendees so they know your guys' answers. So yes, they will be available.
Thank you
Sounds
so
great.
much, everyone.
Thanks,
Thank
everybody.
you. See
Thanks
you
for joining.
soon.